association between prescription drugs and all-cause mortality risk. The UK Biobank has recorded prescription medication and mortality data for over 500,000 patients during more than 40 years. Medications are usually associated with a higher mortality rate. Okay, so without further ado, let's dive into the 14 winners from the UK Biobank prescription drug mortality competition. I think this study kind of pushed me over the edge, so I think I am going to start taking low-dose tadalafil because they're just... My name is Matt Caberline, and welcome to the Optispan YouTube channel. Hey everyone, welcome to the Optispan podcast. And on today's episode, I'm going to dive into a recent preprint that I thought was pretty cool. This comes to us from a company called EPITERNA. And in this preprint, they looked at prescription medications that were taken by more than 500,000 people in the UK over about 40 years and really asked conceptually a pretty simple question, which is if we compare the people taking a particular prescription medication to a group of health-matched people who are not taking that medication, is there any difference in all-cause mortality? And I think the results turned out to be pretty interesting. So there's a couple of things to appreciate here. First of all, this is a preprint. So again, that means it has not yet been peer-reviewed. It was posted on the preprint server medRxiv, which is kind of like bioRxiv, but for more medically or clinically relevant preprints. I also want to state that I was previously a scientific advisor for EPITERNA. And again, EPITERNA is the company that the authors were employed at the time that they did the analysis. So a couple things that are probably also worth mentioning in addition. First of all, this study really couldn't have been done in the United States because in the US, there is currently no way to access the kind of anonymized data that allowed for this sort of research. And there's complicated reasons for that. Some of them having to do with what are, at least in my opinion, overly restrictive HIPAA regulations, and also the medical record system that is most commonly used in the United States, EPIC, makes it really almost impossible for this kind of data sharing and analysis to be done at scale. So this is a place where the UK is just doing it better than we are in the United States. I think there's a lot of really powerful research that could be done if we had these kinds of large data sets available. But I say that also because it's important to recognize that with any of these kinds of studies, human studies are always difficult. With any of these kinds of studies, you know, the associations seen in the UK could very well be different in the United States or other parts of the world. So that's useful to keep in mind. And also important to recognize that all of the results here are going to be correlative, right? So these are not from double-blind, randomized, placebo-controlled clinical trials. So you just have to recognize that that kind of data is weaker than you would get from a clinical trial. In this particular case, I actually tend to weigh these data pretty well, especially when you compare them with other sources of information that kind of support the same general trend. And we'll talk about some of those. I like this study because it's unbiased, right? The authors didn't really go in with any preconceived notions about which drugs they were going to find associated with higher or lower all-cause mortality, really just let the data tell them a story. And I am a big believer in these sorts of unbiased approaches. And in particular, I think too often people go looking to prove a certain hypothesis and can get misled very easily. Whereas when you go in really from an unbiased perspective and just let the data tell you what's important, you're less likely, I think, to get fooled. So I liked the study for that reason. Having said that, even when a study is unbiased in nature, you still need to be cautious about the way that the authors interpret the data. And that's just a general rule. I'm not pointing out anything here that the authors did that in my view was really inappropriate in the way they interpreted their data, but you still need to recognize that the way the manuscript is written is always through the lens of the authors, and you need to ask yourself whether or not their interpretation is really valid given the data that was presented. So with all of that, let's jump in. The preprint is titled Association Between Prescription Drugs and All-Cause Mortality Risk in the UK population. And I'll just read the abstract. So again, always start with the title and the abstract of the paper. Ask yourself whether or not, when you're going through the paper, the data that's presented actually supports the claims in the title and the abstract. In this case, they didn't really make any claims in the title. They're just describing what this study is, the association between prescription drugs and all-cause mortality risk. Okay, so the abstract reads, although most drugs currently approved are meant to treat specific diseases or symptoms, it has been hypothesized that some might bear a beneficial effect on lifespan in healthy older individuals outside of their specific disease indication. So this is just referring to the idea that certain drugs may have effects on health independent of the specific disease for which they're approved, and sort of more broadly speaking, in the longevity field, the idea that certain drugs may target the biology of aging and thereby have a much broader impact on age-related disease and functional outcomes than a specific disease for which they were originally FDA approved for. So rapamycin, of course, is a classic example of this. Such drugs include, among others, metformin, SGLT2 inhibitors, and rapamycin. And we'll get into these in a few minutes. The UK Biobank has recorded prescription medication and mortality data for over 500,000 patients during more than 40 years. In this work, we examined the impact of the top 406 prescribed medications on overall mortality rates within the general population of the UK. So this study is going to be limited to 406 prescription drugs. As expected, most drugs harbor a negative effect on lifespan, probably due to the underlying negative effect of the disease the drug is intended for. So again, not surprisingly, most of the drugs that had a statistically significant impact on mortality tended to be associated with an increased risk of mortality or shorter lifespan. The authors here are hypothesizing that that wasn't due to the drug itself, but probably due to the disease that the drug was prescribed for. That's probably true, but again, it certainly also is possible that some of the drugs themselves had lifespan shortening effects, and that's impossible to really tease out given the nature of the data that's available here. They go on, importantly, a few drugs seem to have a beneficial effect on lifespan. And again, this would be unexpected because most of the time, a drug is going to be prescribed for a specific disease or health concern. You would not expect that, again, if your comparison group is appropriate, and we'll get into what the comparison group is here, that you would see reduced all-cause mortality in the people getting the drug. So in this case, the set of prescription medications that were associated with lower all-cause mortality include notably Sildenafil, Atorvastatin, Naproxen, and Estradiol. And we'll go through all of those. I'm going to take you through all 14 drugs that were found to be associated with lower risk of mortality. And then they go on to say, these retrospective results warrant further investigation in randomized controlled trials. Again, this to me feels like a very appropriately written and worded abstract. They didn't overstate the data. The one thing I might nitpick a little bit is it sort of implies in one place that the drugs themselves are having a direct effect on mortality. I don't know that the authors meant to imply that, but it sort of reads that way. Really, these are correlations, and it's impossible from the data as it's analyzed here to really draw any direct effects, positive or negative, of the drugs themselves on mortality. Okay. So I want to pick out a couple of statements from the introduction of the paper. One was, medications are usually associated with a higher mortality rate. This relation can be explained in part by the potential side effects of the drugs, but mainly because the underlying diseases the drugs are prescribed to treat have themselves an increased mortality risk that the drug is not able to counteract. Furthermore, increased medication in the population is generally seen as an indicator of poor health, and polypharmacy negatively impacts life expectancy of old people. So there's a few concepts there. Again, this is really just noting that you would expect that prescription drugs would be associated with higher all-cause mortality. Could be several things leading to that. effects of the drugs themselves, effects of the drugs in combination with other drugs, polypharmacy, or the underlying disease state or pathology for which the prescription medication was prescribed. So again, it's hard to know exact cause, but that would be the expected effect. The unexpected effect would actually be that you see a reduction in all-cause mortality or improvement in lifespan. So then they go on to say, however, following the geroscience hypothesis, and I'm not really a fan of that phrase, geroscience hypothesis, so you will recall that geroscience simply refers to the mechanisms connecting biological aging to age-related functional declines and disease. If you're not so comfortable with geroscience, we have an entire episode on the channel on geroscience, so I'd encourage you to check that out. I guess the hypothesis here is that if we slow biological aging, it will delay the onset and progression of age-related disease. I think that's not really a hypothesis because it's been proven over and over again in laboratory animals. And I would argue it's really been proven in people as well. We know that lifestyle factors, diet, nutrition, exercise, sleep, all impact multiple age-related diseases. So I'm not sure what the hypothesis part is here. I suppose if you want to argue that biological aging doesn't exist, then it's true that the geroscience hypothesis hasn't been proven. But first of all, that seems kind of dumb to me. And second, you wouldn't believe in geroscience either. So the point is kind of moot. So I guess I'd just like to encourage people to stop using that phrase and simply say that, it follows from geroscience that since biological aging is the greatest risk factor for age-related disease, if we modulate biological aging, we modulate the risk of age-related disease. Okay, so sorry for the rant. That sentence goes on. Some long-established drugs are being proposed to be tested for their protective effect on aging and mortality in a healthy aging population, including metformin, rapamycin, sodium glucose cotransporter 2 or SGLT2 inhibitors, acarbose, angiotensin converting enzyme, ACE inhibitors, or senolytics. So there's no data here on rapamycin or senolytics, but we'll do a quick intro to each of the others in a few minutes. They then go on to say, to date, to the best of our knowledge, a study that comprehensively looks at a wide range of commonly prescribed medications and their association with mortality in the general population is missing. So conceptually, it's very simple. If you can get access to the data for each commonly prescribed drug across the entire population, you can ask if the people taking the drug have a different mortality risk than the people not taking the drug. Obviously need to control for things like age, health status, lifestyle, etc. So they used the UK Biobank to do this. They had de-identified genetic, lifestyle, and health information for more than 500,000 people and prescription medication as well as mortality data for those people. So here they examined this relationship for, again, more than 500,000 people between the ages of 37 to 73 and looked at the 406 most prescribed drugs. So the data set included 501,169 individuals, 56,213,339 prescriptions for 222,058 of the participants. So I don't think that's a typo. That's what it said in the preprint. That's a lot of prescriptions for the number of people that they had as participants. Kind of surprised me how high that was. Again, 406 drugs prescribed to more than 500 people each for at least 3 months. So that was sort of their cutoff criteria. Had to be a group of at least 500 people, and the duration had to be at least for 3 months. The three most prescribed drugs were amoxicillin, which is a penicillin antibiotic, 73,000 plus people. Simvastatin, which is a statin, 45,000 plus people. All statins work by inhibiting an enzyme called HMG-CoA reductase that reduces cholesterol synthesis in the liver. And as I'm sure you know, statins are used to control blood lipids. And then omeprazole, which is kind of interesting. That's a proton pump inhibitor that's used to treat heartburn or acid reflux, 44,100 people there. So for each comparison that they did, they tried to obtain a group of health-matched controls who were not taking the drug, okay? So they were matched for factors having the strongest impact on survival. So current smoking status, cancer diagnosis, had they had a previous cancer diagnosis, diabetes, gender, and age at recruitment. So obviously, you can argue about did they control well enough or not. This seems like a pretty reasonable approach. They didn't give a lot of details on the controls for each individual drug in the preprint, so I didn't spend much time really trying to evaluate how well this controlling was done. But again, it seemed like a pretty reasonable approach to me, so I don't have any reason to be super concerned about that. So out of the 406 drugs that met their criteria, 169 of them had a statistically significant effect on lifespan, and that was after multiple testing corrections. So you'll see this represented as FDR less than 0.05. FDR stands for false discovery rate. So it's just important to recognize that anytime you're testing a large number of things for a statistical analysis, a multiple testing correction is necessary to prevent a lot of false positive results. So again, this should really be done anytime multiple factors or endpoints are being analyzed the same way, but it's especially important when you start getting up into the dozens or hundreds like in this case. So again, one easy way to think about this is to recognize that the typical p-value we use is designed to keep the likelihood of what are called type 1 errors or false positive errors to less than 5%. That's what that 0.05 refers to. So if you just think about it, if you were testing 400 different drugs, each with a p-value of 0.05, just based on random chance, you're going to get about 20 wrong answers, right? Because out of every 100, 5 of them, 5%, will be false positives just by random chance. So the multiple testing correction is simply a way to control for that likelihood of getting a whole bunch of false positives by essentially making it harder to reach statistical significance. So that's probably deep enough for the purposes of this conversation. So they did the multiple testing correction. They used the appropriate statistical methods. So 169 drugs still, even with this much more stringent statistical criteria, met those criteria for being associated with altered mortality risk. Of those, 155 were associated with increased mortality. And again, that's exactly what we'd expect. And we talked about why that might be the case. Could be the drug itself, could be the underlying condition for which the drug was prescribed, could be combinations of interactions between various medications. So that's actually reassuring, though, that we didn't have 169 things that reduced all-cause mortality. Then you'd be kind of like, all right, that seems kind of ridiculous. Probably some more systematic problem in the study. So 155 increased mortality risk, leaving 14 that statistically significantly reduced mortality risk. And again, remember, these are matched against people with similar health status based on smoking, cancer, diabetes, gender, and age. So these 14 drugs are pretty interesting candidates then to look at as potential geroscience or longevity drugs. So again, before we do that, I just want to make it clear, this is nowhere near definitive proof that these drugs directly slow biological aging. And I certainly wouldn't recommend anybody rush out and ask for getting a prescription for these drugs based only on this preprint. But it is kind of interesting, especially when some of these drugs have data from other sources kind of lining up with the idea that they might actually target biological aging. Okay, so without further ado, let's dive into the 14 winners from the UK Biobank prescription drug mortality competition. And we'll start with 14. But before we do this, let's define how we're going to measure the effect on mortality. So what the authors used here was something called hazard ratio. And that's just the measure of how often a particular event, and in this case, we're talking about death, right? This is mortality. How often a particular event happens in one group, the people prescribed the drug, compared to how often it happens in another group, the matched people who were not prescribed the drug over time, okay? So in this case, a hazard ratio of 2 would mean the people prescribed the drug were twice as likely to die in that given time interval than people not prescribed the drug. And a hazard ratio of 0.5 would mean the people prescribed the drug had a reduction in mortality of 50%. So they were only half as likely to die over the same time interval compared to the people that were not prescribed the drug. So we're representing the risk here in terms of this hazard ratio. Okay, so number 14, Atorvastatin. Again, our old friend, the statins. So this is a widely prescribed statin, hazard ratio of 0.91. And it's interesting because statins have been previously reported to reduce mortality in patients with heart disease, clearly. And some studies have also found an impact on people without heart disease. So this literature is a little bit mixed, but there's certainly some evidence out there that statins may have a mortality benefit, even in people who don't have heart disease. And this data generally lines up with that. I thought the thing that was particularly interesting here was there did appear to be a bit of a dose response. So at higher doses, atorvastatin actually had a positive hazard ratio, meaning the risk of mortality was actually elevated. Again, could be due to the underlying disease and not due to the statins. But at lower doses of around like 20 milligrams or even lower, that's where you see the potential mortality benefit, or at least the association with reduced mortality. One of the reasons this is interesting to me is because there's very clear data that the dose response of statins for even something like LDL, right, which is its primary use case, is not linear, meaning you actually get most of the benefit at lower doses of around 20 mgs. And in fact, one recent meta-analysis actually had this quote of statins increasing the dose of each statin to more than 20 milligrams produces only a small incremental reduction in the LDL cholesterol level. The effectiveness of the statins does not increase proportionally with dose, and approximately 2/3 of the expected maximum response can be expected with only 1/4 of the highest dose. So again, I think this is maybe pretty compelling reason to start thinking about, prescribing statins more often at a lower dose of around 20 milligrams or maybe even lower. So, I think if you were on a statin and taking more than 20 milligrams, it might be worth talking to your primary care doc and asking whether these higher doses are really justified in your case. It may be, right? If you need that dose to achieve the effects on LDL, for example, then that makes sense. But, it's worth having that conversation. And again, I thought the association here where there really looked like a pretty clear dose response in terms of all-cause mortality was pretty suggestive. Okay, another interesting thing about statins that might be worth noting is that a different statin, simvastatin, was tested in the NIA interventions testing program in mice and was not found to affect lifespan. So again, I think it's important to appreciate, and I see people make this sort of mistake a lot with the ITP studies, that a negative result from a study, a mouse lifespan study, doesn't necessarily mean that the intervention doesn't increase lifespan. It just means that it didn't increase lifespan in that experiment at the dose tested. And so I think we need to be maybe a little bit more cautious than we often are with just throwing out an intervention because it didn't increase lifespan in the ITP. In this case, it might be that statins in general do not target the biology of aging and do not increase lifespan in mice, and that the mortality benefit here in people is due to something maybe more specific than the biology of aging, like cardiovascular disease risk. That's certainly possible. It's also possible that the ITP picked the wrong statin or picked the wrong dose. It's also true that mice in general do not die from cardiovascular disease. And so it may be that because cancer in mice is generally the lifespan limiting pathology, or at least it's thought to be, an intervention that doesn't effectively modulate cancer risk isn't going to give a big effect on longevity in mice. So all of that's just to say that, I think the question of whether statins really target the biology of aging is still pretty open. And personally, I'm not convinced that they do, but that doesn't mean that they couldn't have a small mortality benefit, all-cause mortality benefit in people. And I think there's reason to think that that might be the case, at least at lower doses. So that's sort of my interpretation of that potential disconnect. Okay. So now let's move on to number 13. Number 13 was Naproxen, hazard ratio of 0.9. Naproxen is an NSAID, non-steroidal anti-inflammatory drug. It's in the same class as aspirin and ibuprofen. So in this particular study, ibuprofen had a hazard ratio of 0.99. So it was not statistically significant, seems to be, no effect on mortality. And aspirin actually had a hazard ratio of 1.17, which was statistically significant, but it was a negative association. So again, I think we need to be a little bit careful not to overreact to the aspirin effect here, because again, we're talking about prescriptions here. So the individuals who are going to be prescribed aspirin are probably going to be taking higher doses of aspirin than we would be thinking about for over-the-counter use, and may have more severe conditions for which they are being prescribed aspirin or another NSAID. So that's just important to appreciate. It's also important to appreciate that NSAID toxicity is a very well-known problem with chronic use in both people and in companion animals. Some estimates suggest that about 100,000 hospitalizations and 15,000 deaths per year in the United States can be attributed to chronic NSAID use. So we want to be very careful not to suggest that people go out and start taking an NSAID for a potential mortality benefit, because at least personally, I think the risks are still probably outweigh the potential benefits. Again, we do have some longevity data for ibuprofen from laboratory studies. It has been shown to increase lifespan in invertebrates and yeast, worms, and flies. I'm not aware of any data in mice. Aspirin did very modestly increase lifespan in the interventions testing program in male, but not female mice. And again, the effect was pretty small. So I think this is interesting. I think certainly, thinking about NSAIDs and their effects on chronic inflammation and potentially beneficial effects in the context of aging makes sense. I don't find this particularly compelling. I'd want to see more data before I really, spend a lot of time thinking about Naproxen or other NSAIDs as a potential, geroprotective intervention in people. As far as I know, there's no longevity data on Naproxen itself from laboratory studies. Okay, so now we are on to number 12, Otomize. I don't even know if I'm pronouncing that right. Otomize. I hadn't heard of this drug before. Hazard ratio was 0.84. This is an ear spray, or at least it's usually used as an ear spray for ear infections. It contains dexamethasone, neomycin, and acetic acid. So dexamethasone is another NSAID. Neomycin is a broad-spectrum antibiotic, typically used for swimmer's ear. So to me, this is a little weird. I don't know if this has something to do with the population in which this drug is normally used. I'm guessing it's typically going to be younger people. So maybe, I don't know, maybe the mortality risk in that population was very low. So this was based on a small number of individuals. Again, possibly this is an NSAID. So I don't know why topical use of the NSAID would make sense, but maybe there's something there. So we'll call it sort of a mystery for now, potentially intriguing, but I just really don't know what to make of that. Okay, number 11. This one to me was pretty interesting. So this is Sildenafil, which is Viagra, hazard ratio of 0.85. So Sildenafil is a member of the PDE5 inhibitor class, same class as Tadalafil, which is Cialis. That had a hazard ratio of 0.86 in this study. Didn't reach the false discovery rate cutoff, but certainly a trend in the same direction. Also in that class is Vardenafil, hazard ratio of 0.89. So again, trend in the same direction. This was something I think may be a mistake. I also saw that the authors had Cialis listed separately from Tadalafil, even though it's the same molecule. That had a hazard ratio of 0.77. I wonder if those were combined into the same group, giving you a higher N. If that would have reached statistical significance, I suspect it would have. So regardless, I think Sildenafil did, and I think as a class, we're seeing that this group of PDE5 inhibitors, which all basically function comparably, are moving mortality in the same direction. So probably most of you know these medications are prescribed primarily for erectile dysfunction, now also becoming more frequently used as a preventative for benign prostate hyperplasia. They are vasodilators, so there's some thought that low-dose use of these drugs can improve circulatory function. They also have anti-inflammatory effects. They're improved for a variety of sort of interesting conditions, including pulmonary arterial hypertension, under investigation for cardiac hypertrophy, myocardial infarction, certain cancers, neurodegenerative diseases, cystic fibrosis, diabetes, obesity, metabolic syndrome. So it's starting to sound like a pretty broad, potentially age-related disease set of conditions here. The data here was only for men, so not enough women taking these drugs to be included in the analysis. But I think, there's the potential here for benefits in both men and women, given, the effects on potentially circulatory function and anti-inflammatory. So for me, this is, like I said, pretty interesting. If you watched the episode on supplements where I talked about the supplements I'm taking and some of the things I'm considering, I had low-dose tadalafil on the list of things that I was considering as, pretty intriguing from a preventative perspective. And I think this study kind of pushed me over the edge. So I think I am going to start taking low-dose tadalafil, because there's just a lot of accumulating evidence that to me is all pointing in the same direction, and the risks seem pretty low. So to me, this feels like it's probably a real result and a real effect that makes sense. Okay, now we're to the top 10. Number 10 is Sumatriptan. So this has a hazard ratio of 0.76. This drug is used to treat acute migraine headaches. It is what's called a serotonin receptor agonist, so to some extent mimics the effects of serotonin. So the links here to mammalian aging are really speculative, but there are studies in both worms and fruit flies connecting serotonin signaling to longevity, and serotonin agonists having been shown to increase lifespan. So this is an area, there's a little bit of smoke, and I would say it's worth further study to see if there might be a connection here to something more fundamental about the biology of aging. Okay, number 9. And this is where we're going to start to see a pattern here in some of the remaining drugs that had a correlation with reduced mortality. Okay, number 9 is Estradiol. Hazard ratio of 0.75. Estradiol is the most potent and abundant estrogen, and it's used as part of hormone replacement therapy to treat symptoms of menopause and also to maintain bone density in women that are going through menopause. Estradiol is interesting for a bunch of reasons. Obviously, there's still some controversy over hormone replacement therapy, potential risks for cancer, which I think have largely been disproven. And certainly there are many, many women who receive a lot of benefits from hormone replacement therapy. So the effects on mortality here certainly could be from the benefits of hormone replacement therapy on things like bone density and frailty. But there's also some reason to think that estradiol and other estrogens may directly impact the biology of aging. Most notably, the interventions testing program found a few years ago now that 17-alpha estradiol extended lifespan in mice, and it's tempting to think that the mechanisms here could be shared. Sort of interestingly, the impact in mice from 17-alpha estradiol was specific to male mice and not female mice. Here, the effect on mortality is only seen for females because not enough men were receiving estradiol in the data set. So here we're seeing what seems to be a pretty clear, significant reduction in all-cause mortality associated with estradiol use in women. In the ITP study in mice, the lifespan benefit was specifically in male mice. And I don't think we still have a very good understanding of why that's the case in mice. So intriguing to think about, what might the effect have been if we had a lot of men taking estradiol, what might the effect have been on all-cause mortality, but we just don't have that data at this point. So estradiol is really interesting. And it gets more interesting because number 8 in the list is Estriol. So Estriol is another estrogen. It's a weaker estrogen than estradiol, with a hazard ratio of 0.74 here for mortality. Again, this is also used to treat symptoms associated with menopause. And again, the data here are only for women, not men. So I think the most likely explanation is whatever the mechanism here is, it's going to be the same for estradiol and estriol. And I think that's almost certain to be the case, although I guess it's formally possible they could be acting through different mechanisms. Number 7, another estrogen, Vagifem, has a hazard ratio of 0.73. This is a vaginal estradiol therapy, again, also used primarily to treat menopause symptoms. So anybody seeing a pattern here? Again, when you start to see the same thing over and over and over again, especially when it's coming out of an unbiased study like this, you really start to believe this is something real. This is something important. I think that there's a clear signal here that estrogen use is associated with lower all-cause mortality in women. And again, the population we're talking about here are primarily going to be perimenopausal and menopausal women that are receiving this prescription. So now number 6, we're going to leave estrogens for a moment. Number 6 was Avaxim vaccine suspension, hazard ratio of 0.71. So the hazard ratios are starting now to get fairly large. So this is a vaccination against hepatitis A. The suspension contains the vaccine, of course, inactivated Hep A virus, along with ethanol, which is alcohol, phenylalanine, an amino acid, potassium, and sodium. So again, I think it's very unlikely that the mechanism here is due to the other additives in the vaccine suspension, and almost certainly the mechanism here is through to the mortality risk, reduced mortality risk in people who got the vaccine versus those who did not get the vaccine. Obviously can't rule out the possibility there could be immune effects, immune stimulatory effects, or other effects of the vaccine on the immune system that are also contributing to a mortality reduction here. But I think it's probably mostly due to the vaccine itself. So regardless, seems like getting a Hep A vaccine might be a good idea if you are in a population where that's recommended. Okay, number 5, we're in the top 5 now. Lymecycline. Again, I'd never heard of this drug before. Specifically, hazard ratio of 0.69. This is a tetracycline family broad spectrum antibiotic. Okay, so this is the second time we've seen a broad spectrum antibiotic show up here. The first one was in that ear spray for swimmer's ear. In this case, Lymecycline is mostly used for acne and also used for some types of bacterial infections. I don't really know the mechanism here. Again, wouldn't really expect topical use to have an effect on mortality, but maybe, or maybe oral systemic use of the drug. It's very speculative, but there is some evidence that tetracycline antibiotics in particular can induce mitochondrial stress, and they've been proposed in the literature to have beneficial effects on mitochondrial function and potentially on aging through a process called mitohormesis. So the idea here is that a little bit of stress is a good thing because it boosts protective responses that then are beneficial in the long run. Again, that's very speculative. For now, I'm just going to kind of chalk this up to who knows. It's an observation, correlation in the data. I certainly wouldn't run out and start trying to get Lymecycline for myself based on this data. Okay, now number 4, we're back to estrogens. So number 4 is Estraderm, hazard ratio of 0.67. This is a transdermal estradiol. And again, data only for women. But seems to line up very well with the pattern here of multiple different types of prescription estrogens delivered in different ways, all conferring a mortality benefit, at least in this population. And number 3, again, following in the theme, Ovestin, hazard ratio of 0.63, another vaginal Estriol in this case. Again, the pattern is clearly there. And it's getting a bit ridiculous. I think more than half of the top 10 are turning out to be estrogens. So sorry, guys, that's the nature of the data. Okay, number 2 is another vaccine suspension, Revaxis, hazard ratio of 0.59. This is the vaccine against diphtheria, tetanus, and polio. Again, very likely due to the vaccine benefits. Vaccines work. And again, I think we need to think about the comparison group here. I'm guessing this is mostly younger individuals. Mortality rate in the group is probably pretty low, but you certainly could imagine there would be a pretty significant mortality benefit to being protected against diphtheria, tetanus, and polio. And then number 1, Marvelon. This is, again, an oral contraceptive containing a synthetic estrogen. In this case, the hazard ratio is almost ridiculously low, 0.18. This is a synthetic estrogen containing 2 molecules, ethanol, estradiol, and desogestrel. I think it's important to recognize here that this is mostly used in younger women. Again, this is a contraceptive estrogen. I actually wrote to the authors and asked about this, and they told me that this was a very low mortality group. That's what you would expect in a younger group. So the total number of deaths was very low, which I think can sometimes lead to skewing of the magnitude of the effect. But again, the hazard ratio here was pretty compelling. And I actually think this might be worth further study. Is it the case that contraceptive estrogen use, even in younger women, can have some mortality benefits? And if so, what does that due to? What's driving that mortality benefit? Okay, so that was the top 14, some interesting things in there. Again, for me, the things that really jumped out was the PDE5 inhibitors, because I'd already been thinking about that, and how strong the signal was for estrogens in women, particularly menopausal women, and correlation with reduced mortality. So then the authors went on and did a few group analyses, again, because there were multiple drugs that were part of the same group. We already talked about a couple of them, the PDE5 inhibitors and the estrogens. So they looked at several groups. The statins, they pooled all the statins together. In that case, had more than 61,000 prescriptions. A hazard ratio, really a very small reduction in mortality, 0.97, but a statistically significant effect of 0.03. Again, this to me is very borderline, nothing to get too excited about, but maybe a small reduction in mortality risk across the entire statin group. Again, remember the caveat here. Now, this is all doses pooled together. I kind of feel like if there's a benefit, the benefit really comes at the lower doses of 20 milligrams and lower. Put all the estrogens together. Again, this is only in women. Hazard ratio of 0.76. Again, very statistically significant p-value of 5 times 10 to the minus 6. PDE5 inhibitors altogether. So this is Cialis, Viagra, that whole group. Hazard ratio of 0.86. Again, p-value of 9 times 10 to the minus 5. So very, very statistically significant. We didn't talk too much about the SGLT2 inhibitors. So I'll talk about this in a minute. This is a group of diabetes drugs that are pretty interesting. Hazard ratio here of 0.64 as a group, even though none of the individual SGLT2 inhibitors came out of the analysis because they didn't have enough people getting the prescription for any individual SGLT2 inhibitor. But when they pulled them together, they had 563 prescriptions. Again, very nice hazard ratio of 0.64, p-value of 0.01. I'll talk more about the SGLT2 inhibitors in a second. Interestingly, the ACE inhibitors here, which are very effective blood pressure medications as a group, had a hazard ratio of 1.1. P-value was very significant, but the mortality risk is going in the wrong direction. Prior meta-analysis actually showed a 10% reduction in all-cause mortality, so not clear why we get differences going in different directions. I think we know that reducing blood pressure is beneficial. So I wonder if this has something to do with the control group here and the way that the control group was identified. I don't think anybody would argue that, taking an ACE inhibitor to reduce blood pressure wouldn't be expected to be beneficial from a health perspective and probably mortality. But maybe when you compare to people who do not have high blood pressure, not taking the ACE inhibitor, then you don't see any mortality benefit. So again, pretty interesting, but a little bit hard to interpret in the context of the broader literature. Okay, so SGLT2 inhibitors. This is worth taking just a minute to do a little bit of a deeper dive. So these are the sodium glucose cotransporter 2 inhibitors. So sodium glucose cotransporter 2 is what it sounds like. It's a transporter for glucose, and it's actually involved in reabsorption of glucose by the kidneys. Okay, so the inhibitor impairs this reabsorption of glucose by the kidneys. And what essentially these inhibitors do is they cause you to pee out more glucose than you normally would. So these drugs have been approved for diabetes, and I would say there's now accumulating evidence for benefits for a variety of conditions, including blood pressure, kidney disease, heart disease, and weight loss. So the SGLT2 inhibitors include drugs like canagliflozin, dapagliflozin, empagliflozin, and ertugliflozin, so all the flozins. And they're interesting in the longevity field because canagliflozin came out of the interventions testing program as one of the more potent drugs to increase lifespan in mice. Now, like 17-alpha estradiol that I mentioned earlier, canagliflozin seems to have an effect on increasing lifespan in mice that is male specific. So it hasn't been shown yet to increase lifespan in female mice. Interestingly, though, the lifespan extension from canagliflozin has also been shown in mice to be associated with delayed pathology or reduced age-related pathology in heart, kidney, liver, and adrenal glands. So this is what we might expect for a drug that's targeting the biology of aging. And I know there's a lot of interest in the biohacker community in the use of canagliflozin or other SGLT2 inhibitors as a way to potentially improve health span, potentially improve lifespan. So this is maybe suggestive data that canagliflozin has effects on all-cause mortality in people, or at least as a class, the SGLT2 inhibitors have a positive effect on all-cause mortality in people. Suggestive, again, remember, this is just a correlation. And again, the group size was pretty small. When you compared all of the flozins together, still was only about 564 people in that total group. So really would like to see more data there, but I think it's kind of suggestive. So there were some interesting things that didn't make the list, and in comparison to the SGLT2 inhibitors, particularly interesting, metformin did not show a positive effect on hazard ratio. The hazard ratio, in fact, was 1.0, very large number of people. This is, I think, maybe not so surprising given some of the more recent findings coming out in the literature that the initially thought to be benefits of metformin on all-cause mortality haven't been reproducible in other populations. And so this certainly suggests that in the UK group, metformin did not confer any mortality benefit. I'm not sure exactly what the comparison group was here. It would be interesting to know, were these people taking metformin compared to other diabetics, or were they people taking metformin compared to other people matched for health but who were not diabetic? So that would be interesting, because if this is compared to diabetics, this would actually be very surprising that people getting metformin who are diabetic compared to people not getting metformin who are diabetic did not have a benefit in terms of all-cause mortality. Doesn't surprise me at all that people getting metformin who are diabetic do not have any mortality benefit compared to non-diabetics not getting metformin. Rapamycin was not in the data set, just not enough people getting rapamycin. Interestingly, testosterone was not in the data set. This is interesting to me for a couple of reasons. Testosterone, of course, is now becoming much more widely used as a replacement therapy in older men. I think the data on whether we would expect testosterone to have a positive or negative impact on mortality are mixed. You can come up with arguments on either side of that. I would really like to see data here. Unfortunately, again, I think just not enough people in the UK data set were being prescribed testosterone. But I think this is actually really important, because I think there are a lot of benefits that go along with testosterone replacement in older men in particular, who are at the lower end of the spectrum for testosterone function. And so it would be nice to know whether there's any impact on all-cause mortality or not. But unfortunately, that just isn't in this data set. So with that, just to summarize the things that I thought were pretty compelling, I like the PDE5 inhibitor effect. And for me personally, that's probably enough to push me over the edge and start taking a low-dose PDE5 inhibitor for broader effects. I thought that the SGLT2 inhibitor data was intriguing, certainly worthy of further study, and I'd like to see a larger data set there. And I think the estrogen effect was clear and robust, and I think certainly adds weight to the argument that for many women, hormone replacement therapy can potentially have pretty broad benefits during menopause and maybe some pretty significant effects on all-cause mortality. So again, certainly worth further study. And for all of these things, I want to encourage you, to have a conversation with your physician. If you found these data intriguing or compelling, certainly worth bringing it up and discussing with your primary care physician. And so I hope that this conversation has been useful. I hope you found it informative. As always, encourage you to leave any questions or comments below. And I hope to see you next time on the Optispan podcast.